For our injuries for the shoulder, we have 4 injuries that we go over today. And we have 2 chronic gradual onset injuries and 2 acute traumatic injuries. So we'll begin with our chronic injuries first. The first one, shoulder impingement syndrome. So we discussed this yesterday in lecture. So it's chronic overuse, usually associated with overhead activities, throwing, swimming, racket sports. And basically it involves the humeral head migrating upwards, so it's pinching structures between the humeral head and the underside of the acromion process. So supraspinatus tendon would be most common, and biceps tendon and subacromial bursa would be other structures that can get pinched. Pain kind of comes on gradually, so there's no specific incident that sets it off, and the more they continue with their sports, the worse the pain starts to get. With our signs and symptoms, when we're looking at their posture, we may see some anterior translation of the humeral heads and internal rotation of the humerus, so the shoulder sitting forward. When we go through range of motion actively, they're going to have some pain with abduction between 90 and 120 degrees, and that's called our painful arc. When they do aptly scratch test, they'll have pain, especially with the arm that's reaching up and behind, and even the arm that's reaching behind their low back, because it's going into internal rotation. We tend to have some discomfort with internal rotation. We may see some winging of the scapula, so the medial border coming off the thoracic cage when they do their wall push-up. And if we do see that, we know we're going to have to strengthen serratus anterior with our scapular punch exercise for our rehab. Our impingement tests, so Hawkins-Kennedy, Neer's impingement, and empty can tests are going to be positive for pain, and maybe even some weakness with empty can tests. And then when we palpate over the supraspinatus insertion at the greater tubercle, that will be sore. So TOP is tenderness on palpation, and they might even have some tenderness through the muscle belly above the spine of the scapula. Treatment: correcting shoulder biomechanics, so anything that we identified, if they have that internal rotation of the humerus and anterior translation of the humeral head, then we're going to need to work on trying to stretch out the internal rotators, so stretching pecs and lats and teres major, strengthening our external rotators, closed chain scapular control, so hand on a small ball or even just hand on the wall, and work on elevating, depressing, protracting, and retracting the scapula, and then moving on to setting the scapula on the back and open chain exercises, so hand no longer touching the wall, and we can try and push their arm in different directions while they try to maintain the scapula in a good position. Before this, we'd be doing our isometric, isotonic, and eccentric exercises. We'll do our strengthening with the arm at the side first before we move on to strengthening with the arm up above. And then we're going to move on to sport specific. So if it's a throwing sport, they're going to gradually progress from throwing from a short distance, maybe 20 feet to 30 feet to 40 feet to 75 feet to 100 feet, increase the number of throws, so 20 throws the first day and moving up to 50 the next time they're throwing, 75 after that. And that's why you hear about in baseball certain pitchers that are restricted in the number of pitchers that they throw. Again, anything that you identify as part of your observation or history, you're going to have to include as part of your treatment. Bicipital tendinopathy, this is another chronic gradual onset injury and also associated with throwing sports or overhead activities. In this case, they're going to have increased pain when they flex the shoulder above 90 degrees, and the pain is right over the long head of the biceps in the bicipital groove. When we do our resisted range of motion, they may have some weakness with shoulder flexion and even some pain with elbow flexion as well, because of the biceps being responsible for elbow flexion. Our speeds test and Jurgensen's test will be positive, and pain right over the long head of the biceps tendon when we palpate it. We may also see issues with their scapulohumeral rhythm. So when we do scapulohumeral rhythm, we may see some winging of the scapula, and that can contribute to biomechanical issues that put increased stress on the biceps tendon, and we may see some winging of the scapula with their wall push-up as well. So again, whatever we identify as part of our observation and assessment, we need to treat that. So if we see winging in the scapula, then our scapular punch exercise. If their shoulders are sitting forward, then stretching our internal rotators and strengthening the external rotators. In general, we're going to do our isometric, isotonic strengthening of the shoulder and rotator cuff with the arm at our side before we move the arm up into the abducted, externally rotated position. And then it's our gradual return to sport. So whatever their activity is, we gradually increase the amount of time that they're doing it, as well as the intensity before we return them to sport. Next, we move on to our acute traumatic injury. So the first one is our shoulder sprain or separation. And when we hear shoulder separation, it's referring specifically to the AC joint, the acromioclavicular joint. Traumatic injury, usually an impact to the lateral side of the shoulder, especially from lateral and driving downwards on the shoulder. So it pushes the acromion process downwards, or we're tackled and we land shoulder first and person lands on top of us, or hit into the boards in hockey, for example. So even with our grade 1 injury, this can be quite painful, and so they're not going to want to move their shoulder at all. So range of motion is going to be decreased in all directions. If we do strength testing, they'll have weakness when we test all movements of the shoulder. They're not going to be able to reach their arm across their body because the clavicle acts like a stretch or a brace, and as we try to reach across, it puts increased stress through the AC joints. And if we push downwards on the acromion process, there's going to be increased laxity and pain as we do so. So treatment, police will have them in a sling until the weight of the arm is no longer painful, and then we start working on range of motion. So initially passive range of motion, where we move the arm for them only within a comfortable range. We can do pendulum exercises where we're letting the arm hang and we move our body side to side to get the arm moving, so they're not actually using the muscles that attach to the shoulder. And that's a simple way that we can increase range of motion. Strengthening, isometric, isotonic, strengthening with the arm down at our side before we move on to strengthening with the arm up above in an abducted, externally rotated position. Our scapular stabilization exercises apply here as well. When we return them to sport, we want to pad the AC joint so it's not getting impacted again. And then our AC joint tape job, then I'm going to demonstrate in one of the videos today. Again, you're not responsible for the AC joint tape job for your taping final. The video is just for your own information. And particularly if we're seeing quite a bit of a step defect when we do our observation, we're going to send the athlete to the hospital to get x-rays just to make sure they don't also have a fracture of the clavicle. And then our final acute traumatic injury for the shoulder lab, shoulder subluxation dislocation. Remember, subluxation is where the head of the humerus almost comes out of joint and slides back into place, and dislocation is where it completely comes out of joint, usually moves anterior inferior, and the humeral head ends up in the axilla or armpits. And in that case, sometimes the head of the humerus will relocate itself by the athlete moving their arm around, but in most instances they'll have to go to the hospital and have it relocated, and usually they're sedated or given laughing gas to allow the muscles to relax. So mechanism of injury, they can fall on their shoulder, they can fall on outstretched hands, maybe tackled and landing directly on the shoulder. If you come upon your athletes and they say, I think my shoulder has popped out or it's out of joint, the extent of your examination may be, if they're wearing equipment, reaching your hand up underneath their jersey and equipment and feeling for the head of the humerus in the axilla or armpit, and seeing if they've lost that normal rounded deltoid contour. If it feels very bony on the lateral shoulder, like we saw in some of our basketball videos yesterday, and we suspect that they still are dislocated, then that's it. That's the end of our assessments, and we're going to put them in a sling and get them to the hospital for an x-ray and for the doctors to relocate it. But if they say, I think it popped out, but it's back in, or they say they think it still popped out, but you don't feel the head humerus and the axilla, and you palpate and they have normal rounded deltoid contour, you're going to cautiously move on with the rest of your assessment. It's just that we don't want to be doing range of motion and strength testing in our orthopedic tests on a person that currently has a dislocated shoulder, because of that possibility of causing some nerve damage or compressing the blood vessels traveling down into the arm. For range of motion, we'll go through all 6 movements of the shoulder: active, passive, resisted, and range of motion is going to be decreased in most directions. Strength is going to be decreased in most directions. When we do our special tests or orthopedic tests, our sulcus sign may be positive. Anterior posterior glide, they'll have increased movement of the humeral head on the injured side. And our apprehension tests, they're not going to want to go back into that abducted and externally rotated position, because they're going to feel like it's going to pop out again. So that would be positive. They'll show fear and apprehension. Treatment for subluxation: police. When the weight of the arm is no longer painful, we're working on range of motion: passive, active assisted, active. Strengthening, isometric, isotonic, strengthening with the arm at our side before we move on to strengthening with the arm in the abducted, externally rotated position. And scapular stabilization exercises. For dislocation, again, we treat it like it's a fracture, put them in the sling, get them to the hospital. They're going to x-ray to make sure there is no fracture. And then we go through our rehab that we talked about in the shoulder lecture yesterday. So keeping them in the sling while the weight of the arm is painful, working on general cardio conditioning, stationary bike, maybe elliptical with only one arm on the handles, walking, jogging when the impact on the ground is no longer painful for the arm. And then our range of motion with pendulum exercises or the pulley, strengthening, isometric, isotonic, strengthening with arm at side before we move on to strengthening up in our 90-90 position, scapular stabilization, gradual return to sport. So you'll notice that the rehab for really all of our shoulder injuries is pretty well the same. So you can mention that as part of your treatments. For the injury scenario, from the history, you're going to be able to narrow it down to a chronic gradual onset injury or an acute traumatic injury, probably within the first sentence. So for your diagnosis, if it's a chronic gradual onset injury, you're going to say shoulder impingement syndrome, likely supraspinatus, or bicipital tendinopathy. If it's an acute traumatic injury, then you can narrow it down to your AC joint sprain, and you might be able to give a grade. And similarly, either shoulder subluxation, dislocation, depending on the severity of the injury. So that's it for our injuries for the shoulder lab.